in this video, I just want to go over this particular radiograph that came up in your exam, because there were some parts that everybody did quite well, but there were a couple of lesions on here that almost everybody missed, and I just want to highlight them to you. So basically I'm just going to talk through this entire radiograph in terms of the report, so you know the type of things that we were looking for, and you'll have a better idea of where you gained or perhaps failed to gain some marks. So this is a right bite wing, and in terms of the teeth present, we've got an E, D and a C. So they're on the right, so we've got the 5-5, the 5-4, 5-3, and then on the lower we've got the 8-3, 8-4, 8-5. Now, in terms of bone levels, this is a child. There's no evidence of sixes yet. So this child is 5, maybe 6 years old. These bone levels are normal. A few of you mentioned bone loss in this sort of area or this area here. That's not bone loss, that's normal bone levels in a child. The sixes are in this vicinity. In fact, I would say this here is perhaps just the very edge of a cusp of a 6. So there is no bone loss, and you wouldn't normally expect to see, in fact, not even just expect to see, it would be highly unusual and unexpected to see bone loss in a child's mouth. So in terms of the radiograph, I would simply be describing that as either you could say healthy or normal bone levels, or in an adult with no bone loss, you would generally say like bone loss less than 10% or something like that. But in a child, just normal or healthy bone levels would be fine. Sorry, I've skipped a little bit ahead to pathology there. In terms of other anatomy, there isn't really much to say. There's no restorations in here, nothing like that. So teeth present would be the anatomy, and that there's normal bone levels. Now, in terms of pathology, pretty much everybody got this radiolucency here, as I would hope, and I think we can all agree that that's very much into pulp, therefore it would be an ICDAS RC6. The other one that a lot of people got was the radiolucency on the E in this region. A lot of you described this as an ICDAS 2. And RA2 would suggest that the caries had remained within enamel, but in actual fact, if I draw the outline of this lesion, whilst it starts in enamel here, apologies, I need to not press so hard, it comes round here. So that lesion is definitely into dentine. We need to remember that we're talking about deciduous teeth here, so the enamel is very thin. Your ADJ is there. So if this was ICDAS 1 or 2, so it remained in enamel only, you would only be thinking about this little bit of the lesion here. But in actual fact, it progresses right into there. The other one that a lot of people found no problem was the lesion in this tooth here. Again, a lot of people describe this as ICDAS 2. Now your ADJ is running about there, and we can see that the lesion progresses into the dentine. Therefore, that's also an RA3. There is a very small lesion here, which actually the majority of you found, and I would describe that as 1 or 2, which was accurately done. There are 2 more lesions, however, in these radiographs that very few of you pointed out. However, they are large restoration, large radiolucencies. First one is here. So in the occlusal portion, distal occlusal portion of the 5-5, that's an extensive radiolucency. Arguably there is still a band of dentine here, so we'd have accepted RC5 for that, but it's definitely there. And I'm not really sure why so few of you found that, because it is really quite an obvious one. The other one is an even bigger lesion, and that is in this 8-5 here. So the lesion starts, that's your sort of entry point through the enamel. However, it is all this area. Now, we cannot tell just from the radiograph. I suspect, just with the benefit of my experience, that what this would look like in the mouth would be very chalky looking on the surface, very opaque looking. And when you went into that cavity, you would find that all that was there was a shell of enamel, and the dentine is almost entirely carious inside. This is a huge carious lesion, and this is definitely into pulp, so it would be an RC6. There is no definition between pulp and radiolucency there. So in total, we've got 1, 2, 3, 4, 5, 6 lesions, 6 radiolucencies on this radiograph, and the upper E's, both E's, the upper and the lower E's, a lot of you were recognising the radiolucencies on the mesial portion, but not on the occlusal portion. So you want to try and be methodical with your radiograph reporting. Sometimes it's easy when you've got such a blatant cavity on a radiograph like you do on the 5-4 here, to allow your eyes to be drawn to that. But I would always start on one side of the radiograph and work your way around. For me, I start on the top right hand side of the radiograph. I don't mean the top right of the mouth. In this radiograph, that's the same thing, but if it was a left bite wing, that's where I would be starting, in the top right hand corner of the radiograph. And I would do all the upper teeth, working towards the right hand side. Sorry, I've got that the wrong way down, haven't I? I would start on the top left of the radiograph, top left corner, work towards the top right, and then I would start on the lower left of the x-ray and work towards the lower right of it, to make sure that I'm looking at every possible feature that could be there. So I hope that's helpful in terms of feedback. I would really encourage you to look at as many x-rays as possible. Every time you see a patient, regardless of what they're in for, look and see if they have any previous radiographs that you can use. You can practice writing reports on any radiograph, doesn't matter whether you took it or not. Just look at them, identify if you've got spaces in your appointment book, perhaps just go for some random x-rays that you can find for patients that are in your appointment book, and ask the tutor that's with you if they can have a look with you and see if they agree with what you're saying.